I'll be talking a little bit about a manuscript that will be published in JSCAI today. It's a pleasure to be here today, and I'm grateful to JSCAI for highlighting this research. We looked at long-term incidence of MI and death after CABG and PCI for isolated LAD disease, and this was a meta-analysis of randomized controlled trials. These are my disclosures. So some key background information is optimal revascularization strategy for isolated LAD disease is unknown due to limited contemporary randomized controlled trials. Most of the trials that looked at this, and we'll go over this, looked at this in a pre-drug-eluting stent era and a pre-intravascular imaging area and before surgical techniques were as optimized as they are today. CABG has been suggested to be associated with improved outcomes and protection from MI due to bypass of vulnerable plaque. And this has been touted a lot in the surgical literature, where the thought has been that a LEMA will bypass any potential vulnerable plaque that's present in the proximal vessel that a stent would not be able to necessarily treat, because we're only treating a particular lesion as opposed to the whole vessel by bypassing it. Despite these postulations, however, PCI is often used for isolated LAD disease due to its non-invasive approach and patient preference. The objective of our study was to conduct a systematic meta-analysis to evaluate the long-term differences in outcomes in patients undergoing CABG with the LEMA versus PCI with the stent for isolated LAD disease. Essentially, the question that we were trying to answer was, does CABG with the LEMA protect against MI versus PCI? Our hypothesis was that CABG does not confer a long-term reduction in MI and death when compared to PCI. These were our methods. We conducted a comprehensive search of eligible studies dating from January 1st, 2002 to June 4th, 2022. We had 2 additional investigators review the eligible studies and ensure that they met inclusion criteria. And our inclusion criteria were as follows. We looked at randomized controlled trials that were randomizing patients to PCI with a stent versus CABG with the LEMA in patients with isolated disease. We looked at only studies that reported an incidence of death and MI. There were some trials that did not report an incidence of MI, and those studies were not included. The reporting of target vessel revascularization or failure was optional, and the follow-up duration was greater than 4 years was the minimum. And so again, there were many studies that had follow-ups of 6 months, 1 year, 2 years, but we were really looking at long-term follow-up for the purposes of this study. Data extraction was performed by 2 independent investigators and then confirmed by a 3rd. The primary outcome of interest we were looking at was occurrence of MI, Q-wave and non-Q-wave MI at the latest follow-up. And then we also looked at secondary outcomes of all-cause death and target vessel revascularization. And statistics were performed according to the Cochrane collaboration recommendations using R. So this was our initial flowchart. So you can see here we identified 2,239 patients using the searches, and then there was an additional one study that we identified through a different sort of search. And then we removed all of the duplicates and came down to 2,187 studies. We screened all of these and excluded 2,166. So, and the full articles that were excluded, there were 4 meta-analyses, there were 4 case reports, there were some that were not restricted to LAD disease, and then some that didn't evaluate stent placement, where they were just looking at PTCA. And finally, we ended up with 4 studies in this meta-analysis that were eligible. These are the studies that were included. You can see in terms of range, these range from 2004 to 2015 in terms of dates. They're mostly all performed in Europe, and in terms of follow-up, they're ranging anywhere from 4 years to 10 years of follow-up. These were small numbers of patients in each of the studies, and that's a limitation that we'll discuss. The patients were ranging anywhere from about 59 years to 62 years. They were mostly male, as has been a limitation of many of the studies performed, especially during that time. 100% of patients in these studies had a LEMA use. We did exclude one study that was using vein grafts as well, as we didn't think that that would answer our question appropriately. 100% had stents, so these were not patients that were treated with PTCA. These were all patients that received a stent, but only 3 of the studies, only one of the study had drug-eluting stents, whereas 3 was mostly using bare metal stents, and that's again given the time period that these trials were performed. Our results are as follows. There was no significant difference in the risk of MI, and you can see the heterogeneity here was 19%. There was no significant difference in the risk of mortality, the heterogeneity of 0. There was less TVR with CABG, as we could expect, and the p-value here was less than 0.01. And essentially what we concluded based on this is that MI did not confer any protection against MI with the LEMA. And so the limitations we have for our study are, first, there's inherent variability in the patient populations given multiple studies that were included. RCTs generally include a highly selected group of patients and thus can exclude higher risk cohorts in whom equipoise between PCI and CABG does not exist. That's something we see even with current trials where a patient that you may know what therapy you want to deliver to them may not end up in these trials, and that's something we have to take into account. The follow-up time varied between the studies. The timing of outcomes was not able to be ascertained, and so while we looked for patients that had been followed for an extended period of time, we don't have the information as to when the MI actually occurred. And so while we were saying this is long-term MI, the MIs could have happened within the first year, and so that's a major limitation. There's no information regarding the anatomic complexity of these lesions, the location in terms of proximal versus distal in the vessel, and procedural characteristics. And there's no contemporary data available in any of these studies, and so this isn't really reflecting our current practice of PCI or the current surgical practices. Our conclusions are that first, CABG is often suggested as superior to PCI because of protection from long-term MI due to bypass of vulnerable plaque. Our study suggests that there's no reduced risk of long-term MI or mortality with CABG when compared to PCI. Further studies examining the origin of MIs after CABG and PCI with attention to the etiology of MI is important. And we're working on pooling these data so that we can perform some pooled individual patient analyses that may help address some of the limitations and may help shed light on the timing of some of the MIs as well as some of the anatomic characteristics of the lesions. Thank you.